Good afternoon, Commander. I'm Dr. Sabarish from Lakshmi Narayana Medical College, working as an assistant professor in orthopedics. Today, we are going to see about Monteggia fracture dislocation. Historically, it is defined as a fracture of the proximal third of shaft of ulna with dislocation of the radial head. Going into the history, it was first described by Giovanni Battista Monteggia, who is a surgical pathologist who studied it in the cadaveric dissection, and he defined as a fracture of the proximal third of the ulna and an anterior dislocation of the proximal epiphysis of the radius. Next, the Monteggia fracture constitutes about 1 to 2% of the forearm fractures, along with other fractures such as distant radius fractures, DRUJ disruptions, and other ulnar radius fractures. The most common classification we use is the Badow's classification, which was described by Jose Luis Badow in 1958, who divided it into the 4 components based on the types of fractures and the patterns and the mechanism involved. Badow classified certain injuries as equivalents to the classic of true or Monteggia violations because of the similar mechanism of injuries, the similar radiographic pattern, or the methods of treatment. They are also most commonly seen. This is a pictorial representation of the Badow's classification, which is divided as type 1, 2, 3, and 4. I'll elaborate each and every types. In Badow type 1 classification, there is a proximal shaft of ulnar fracture, along with disruption of proximal radial joint, where there is an anterior dislocation of the radius. As you can see here, the radial head is dislocated anteriorly. This is the most common type. This is the most common type of Monteggia fracture seen in adults and due to fall from height or traffic accidents. Coming to type 2, here along with the proximal ulnar shaft fracture, the radial head subluxation or dislocation is posterior or posterolateral direction. There is usually fracture along with the metaphysis of the ulna. It is the most common type, which is associated with the neurovascular injury leading to the pin palsy, leading to poor prognosis. Pin palsy causes finger drop. Pin is a branch of radial nerve. Okay. Coming to the third type, here there is a proximal 1/3 shaft of the ulnar fracture along with the lateral dislocation of the radial head. As you can see, in type 1, there is an anterior dislocation of the radial head. In type 2, there is a posterior dislocation of the radial head. Here in type 3, we can see there is a lateral subluxation of the lateral dislocation of the radial head. Type 4, there is an anterior dislocation along with the radius shaft fracture. From the first 3 types, we have seen there is an ulnar shaft fracture along with dislocation of the radial head. In the type 4, there is an additional mechanism which involves radius leading to radial shaft fracture. This pattern of injury is same as type 1 injury with inclusion of a radial shaft fracture below the level of ulnar fracture. Due to the level of fracture is below the ulna. Why? Because there is a distribution of force along the interosseous membrane leading to torsional activity leading to radial shaft fracture. Lett's classification is also one of the most common, not so common, but used in pediatric classifications. Here there is the Badow type 1. This is interrelated with Badow classification. Lett's classification type 1 consists of Badow type 1 along with subdivisions. A is the anterior bowing of ulna due to plastic deformation with anterior dislocation of radial head. As you can see, in pediatric age groups, there is a plastic deformation is very commonly seen. In type B, it includes a green slit fracture of the ulna, whereas in type C, there is a complete ulnar fracture linear to adult fractures. Here there is a pictorial representation of types of Lett's classification. In type A, B, C correlates with Badow type 1 classification, where there is an anterior radial head dislocation. In type A, there is an plastic deformation of the ulna. In type B, there is a green stick fracture. In type C, there is a complete ulnar fracture. Type D correlates with Badow type 2, where there is a posterior dislocation of the radial head. In type E, there is a lateral dislocation of the radial head, which corresponds to Badow type 3. Again, this is a, as you can see in, as you already seen in picture, this is bladder type 1, 2, and 3. Mechanism of injury. Mechanism of injury is the most common thing for any fracture to occur. We should understand the basic mechanism of through which the fracture occurs so that the reduction techniques can be proper and the fixation techniques can be easy. So coming to mechanism of injury, the in type 1, where there is a proximal one-third ulnar fracture along with anterior subluxation of radial head, which is led by a patient falling with the forced pronation of the forearm. When the forearm is pronated, leading to the injury, when the forearm is pronated, which causes injury leading to type 1 bladder, which is the most common type. In type 2, there is an axial loading of forearm with flexed elbow, which leads to the posterior dislocation of the radial head. In type 3, there is a forced abduction of the elbow, which causes the radial head to dislocate laterally. In type 4, there is a forced pronation of the forearm, in which the radial shaft additionally fails in communication with the interosseous membrane. This is a pictorial representation where you can see the patients falling with an outstretched hand with the pronated forearm, leading to type 1 force. In the second picture, you can see the patient falling with elbow flexed, leading to posterior dislocation of the radius along with the proximal shaft ulnar fracture. In type 3, the patient falls with forced abduction of elbow, leading to lateral subluxation of the radial. So the most common mechanism of all these is the fallen outstretched hand, either with the elbow either in with the forearm in pronation, elbow in flexion, and an abduction force. These three causes the three types of fracture. If the injury is severe enough, it may cause the radial shaft fracture leading to a type 4 bladder classification. And we should not forget about the other equivalents of Monteggia fracture, which may involve the radial head fracture, radial neck fracture, or dislocation of the elbow. Everything happens. Okay. Clinical evaluation. When the patient comes to you, usually the presentation of the patient is with a history of trauma or history of fall with a fusiform swelling around the elbow. The painful restriction of movements is seen in the affected patient where the flexion, extension, pronation, and supinations are affected. The movements possible around elbow joints are entirely affected due to swelling and fracture. So we should carefully evaluate the neurovascular structures involved in that area because the type 2 fracture is more prone for pin nerve palsy, which is posterior interosseous nerve. Posterior dislocation of the radial head may cause injury to the pin structure present over there, posterior interosseous nerve, which may lead to finger drop. Therefore, the neurovascular examination plays a vital role. How you should examine? We should check the distal pulse to check the intactness of the neurovascular structure and to carefully examine the neural structure, which is a pin nerve. You can ask the patient to simply to extend the finger and the wrist to examine the pin nerve palsy. Pin will cause finger drop, whereas radial nerve will cause wrist drop. Radial nerve and posterior interosseous nerve injury are common in type 2 fracture, as I already explained. Therefore, dorsiflexion of wrist and dorsiflexion extension of finger is carefully observed, and it should be done by placing the forearm and the wrist in a neutral position on a table, and the patient has to extend the fingers and wrist to look for the intactness of the radial and posterior interosseous nerve, which is also a branch of radial nerve. Coming to radiographic evaluation, any patients coming with elbow injury or any other injury, the most common way orthopedically used is X-ray, basic investigation. Here we go for anteroposterior and lateral X-rays of the forearm and the elbow, and we should not miss any DLJ disruption or any distal fracture. Therefore, the entire forearm along with the elbow is taken. The radio. How come we if there is a subluxation or a dislocation of the radial head, how come we can radiologically diagnose? Is that by the best method is radiocapitellar relation. If you draw a line along the shaft of the radius, it should intersect the capitulum at the humerus bone. So if there is a disruption, if there is an anterior dislocation, the line along the shaft of the radius will cross the capitulum above the capitulum in the humerus. If there is a posterior dislocation, the line lies well below the capitulum. So basically, you should know a line drawn along the long axis of the radius, which bisects the capitulum of the humerus, regardless of the degree of flexion or extension of the elbow. This is the most important point. Either when you keep the elbow in flexion or extension, it doesn't matter. Always the line drawn along the shaft of the radius will bisect the capitulum of the humerus in any position. So in case of dislocation of the radial head, so we can easily radiologically diagnose the dislocation of the radius. This is the radiocapitular relationship. As you can see, this is various position. The first image is a full flexion of the elbow, and there is a partial flexion of the elbow, and there is a complete extension of the elbow. In all the cases, the circle structure is the capitulum, and when you draw a perpendicular line along the axis of the radius, it always intersects the capitulum of the humerus. So whenever there is a subluxation or a dislocation, it either lies above or below the capitulum depending on the dislocated side. Management, first, it depends on the patient status. Either it is a pediatric patient or an adult patient, and also based on the type of fracture. There are various reductive methods for various types of Monteggia fractures. It is also a fracture of necessity. What is a fracture of necessity? Uh, there is an ulnar fracture along with radial head dislocation. So once you go for reduction techniques, you should take and check X-ray to observe whether the reduction is absolutely fine. To go with conservative management along with the reduction of radial head. So it is a typical fracture where we most probably end with surgical fixation of the ulna, and the radial head will automatically correct. If there is an failure of radial head correction, we go for surgical technique, which involves the fixation of the radial head in the annular ligament. So the non-operative and operative methods are there. Non-operative is reserved for the pediatric population. So as I already told with Let's classification, where in type 1, A and B, there is a green stick fracture and there is a plastic deformation, which can be well corrected with, which can be, if properly reduced, it can be corrected by conservative management. So here in type 4, there is a radial angulation correction, which is done by traction, the longitudinal traction along with supination, which converts the type 4 fracture into type 1 fracture, and there is a full flexion of the elbow with 80 to 100 degree flexion of elbow, and there is a above elbow slab is applied. So here, what we are basically doing, there is an subluxation type 4, there is a radius fracture and an ulnar fracture along with dislocation. So we opt for traction, supination, and flexion, leading to reduction of the fracture along with reduction of the radial head. If the check X-ray is super enough to be managed conservatively, it is well and good. Otherwise, we go for surgical management. The basic principle involved is the elbow is extended, abducted, pressure over the radial head is given, supinated. Immobilization is done with the flexion at 90 degree or more, depends on the types of fracture. So these are the various methods. In type 2, we go with traction, inflection, and pronation of the forearm. Why? Because there is a posterior dislocation of the radial head. Posterior dislocation will automatically get corrected in the pronation of the forearm. So we here immobilize with the flexion flexion of 60 degree. How will you maintain the reduction? Reduction is maintained by above elbow cast inflection for 6 to 8 weeks. The degree of flexion varies depending on the direction of the radial dislocation. So this is the most important point. When the radius is in a straight lateral or anterolateral position, for example, lateral or anterior position, flexion to 110 to 120 degree is done to give important stability. If there is a posterior or posterolateral component to the dislocation of the radial head, a position of 70 to 80 degree flexion is sufficient enough to keep the radial head intact. So forearm rotation usually is in supination, which tightens the interosseous membrane, which further gives mechanical compression over the fracture site for helping reduction. So the take home is when the radius is anterolateral or lateral, the flexion is 110 to 120 degree, whereas in the posterolateral component, it is 70 to 80 degree. As you can see, the first, there is an anterior or anterolateral fracture. The image given in die 4, therefore we give 100 to 110 degree of flexion along with supination of the forearm. In case of posterior, as you can see in the second picture, we are giving a flexion of up to 80 to 90 degree, sufficient enough to maintain the reduction of the fraction. And the period of maintenance is 6 to 8 weeks, and periodically it should be checked after 2 to 3 weeks whether there any unstable radial head leading to dislocation again. So we are coming to the management as proper management, which is the operative method. This is the treatment of choice. Why? Because there is a joint involved and there is a proximal shaft of ulna fracture. It is highly difficult to get the appropriate reduction to go in for conservative management. Therefore, the conservative management is meant only for pediatric fracture, whereas in adult type of fracture, Monteggia variants, we go with surgical fixation. What are the methods available? Basically, any long bone fracture, we either go for intramedullary nailing or plating. Here in ulnar radius fracture, we usually opt for 3.5 mm plate, which may be an interlocking plate, or low contact DCP plates are available. So the plate is applied always on the tension side. This is the treatment of choice. The plating of ulna, open reduction, internal fixation. Here the reduction is very difficult, and hence we go for open reduction internal fixation with the 3.5 mm contour plate, or intramedullary nailing is most commonly used in a pediatric or adolescent population where open reduction internal fixation is a bit complicated. Plate is applied whenever you apply, you will go for 3.5 system. The plate is applied always on the tensional side rather than the compressive side. The closed reduction of the radial head is ruled once ulnar length is achieved by open reduction internal fixation. When you go for the approach which reduces the ulnar fracture with plating, the radial head will automatically gets corrected. This is the rule of Paul given. And the failure of closed reduction of radial head after reduction of the ulna with plating, there we go for open reduction maneuvers leading to reduction of the radial head. This is a rare phenomenon. Once the length is corrected using the fixation of the radial ulna, the radius will automatically reduce from its dislocated position into the annular ligament. If it is not reduced, so we go for surgical management of the radial head by fixing it. Radiocapitular pinning or fixing the radial head and keeping the patient in abdominal slap in flex position for 6 weeks. Posterior elbow splint is applied, followed by the physiotherapy, where the physiotherapy rehabilitation is very important, starting after 3 to 4 weeks. Limited movement of elbow, flexion and extension, gradual exercises, and supination and pronation is also to be taught and to be maintained properly. The complications are very important in this case since the elbow joint is involved. The neglected Monteggia fracture is not very uncommon in pediatric and adults, where they go for native bandaging, thinking that it is a hematoma or soft tissue injury, neglecting the fracture, leading to neglected Monteggia fracture, which is very difficult in future for reduction, which will affect the supination and pronation movements of the elbow. The non-union is also any fracture may lead to non-union, which might be due to the abnormal reduction of the fracture site or any other systemic factors which affects the healing of the fracture. Which is most commonly, non-union is most commonly seen in type 2 fracture, where there is a posterior dislocation of the radial head, which there is a proximal third ulnar fracture along with the posterior dislocation of the radial head, where the non-union is most commonly seen. As I already told, no injuries are not to be missed in any type of fracture. The patient may present with difficulty in moving the affected part of the limb, and hence we should be careful enough to examine the extremities to look for the movements and vascular blood supply by checking the distal pulse, radial pulse, and the pin structures, radial structures, or radial nerve are examined by appropriate finger movements and wrist movements. The radial, median, anterior introitious nerve, posterior introitious nerve, or maybe either injured traumatically or iatrogenically. Iatrogenically, when we go for surgical incision, there is a chance of while we go for when we go between the planes of supinator muscle, there is a chance of pin nerve palsy. So therefore, to know whether the radial pin nerve palsy caused by iatrogenic, we should know whether it is present priorly before surgery due to various causes, or it is caused by iatrogenic during surgery. Therefore, careful neurovascular examination when the patient's presence initially is very important, which differentiates the pre and post surgical complications. Periarticular ossification or heterotrophic ossification is very commonly seen around the elbow. This is known as heterotrophic ossification, or this is seen around the elbow. The brachialis muscle will go for ossification. Once ossification is seen, it is very difficult for the patient to carry out the routine activities. Flexion and extension will be affected, and other movements is also affected. The compartment syndrome is not also very uncommon, leading to any vascular injury or profuse swelling around the elbow will cause compartment syndrome due to radial head instability. The compartment syndrome will itself cause the ischemic necrosis of the vascular neurostructures and muscles present over the elbow, leading to Workman ischemic contracture in case of distal radius fracture. As you see, VAC there, the compartment syndrome around the elbow leads to necrosis of the muscles around the elbow, and therefore the identification of the compartment syndrome, which you know already by 6 P's, the pallor, paresthesia, pulselessness, which pain, passive stretching pain, and through these components, the compartment syndrome is quickly and routinely identified, and if needed, fasciotomy is performed to avoid the complication of necrosis and other structures. So, the Monteggia fracture, as classified by Bado, is of 4 types. Type 1, 2, 3, 4. In case of pediatrics, it is by Latz classification. So, the proper classification and identification of the fracture is observed, and the appropriate treatment management is seen. So, if there is an anterior or anterolateral, you should go by 110 to 1 degree flexion with the A slab, and if it is a posterior, you go with 80 to 90 degree flexion of the A slab of the elbow joint. So we should not mention about, we should always keen on checking the neurovascular structures. Our surgical planning should be adequate with proper plating methods to enforce the proper reduction of the ulna, and if there is, after reducing the ulna with 3.5 plating system, we should use the fluorescence technique or intraoperative CM to check for the reduction of the radial head. The radial head reduction is checked by when a line drawn along the shaft of the radius will bisect at the level of capitulum. We say the position is good. If it is above or below, the radial head is said to be in an abnormal position. So non-anal is also not uncommon. Periarticular ossification is also not uncommon. So these are the most common complications of the Monteggia fractures. The Monteggia variants also very important. They're also seen around the elbow joint. Many variants are seen, more than 10 types are seen, where there is a ulnar fracture, proximal, which means olecranon process fracture, along with radial head dislocation is also a variant of Monteggia fracture. Radial head fracture or radial neck fracture along with dislocation with proximal one-third radius ulnar fracture is also most common thing. And this Monteggia fracture is most commonly seen in persons falling with elbow in flexed and pronated position. If there is a assault by some other persons leading to protection, where the patient covers the hand with the arm pronated, leading to ulnar fracture and radial head subluxation. These are the most common type of Monteggia, most common fracture seen as we see in orthopedic OPD, where we go for surgical fixation, and the surgical fixation procedure involves 3.5 plating system. Along with, we should have adequate cortical purchase for the fracture to be rigidly fixed, and the radial head should be checked intraoperatively and should not be missed as a grave mistake. The post-operative rehabilitation involves appropriate movements. First, the dressing should be done at the third day and sixth day to keep the surgical site intact, followed by proper and sterile dressing methods. And then at the end of 14th day, we go for suture removal. And by the end of 3 weeks, we remove the post-operative slab applied, and we gently ask the patient to mobilize the elbow joint. Supination, pronation, and flexion extension is gradually done till it reaches the full range of movements. By the end of 6 to 8 weeks, the patient's flexion should be approximately around 120 degree and extension should be full. There should not be any extension lag, and also various methods are used for the mobilization methods. And heterotrophic ossification is very uncommon fracture, very commonly seen around the elbow fractures. Therefore, it should not be missed. As a preventive measure or a prophylactic measure, we give indomethacin as a prophylactic drug, which helps in reducing the heterogenic, heterogenic ossification, and appropriate post-operative follow-up and rehabilitation is also done. So other most common fractures around the elbow are terrible triad elbow, which is a posterior dislocation of the elbow along with coronary process fracture and a radial head fracture. And other radial head and radial neck fracture, if it happens in Monteggia variants, we go with a replacement of radial head. We can replace the radial head if it is not prone for fixation, or if it is a fixable fracture, we go with a plating or a Herbert screw, which is a headless screw used for most commonly for scaphoid fracture and radial head fracture. And if needed, nailing is or plating is used for radial fracture in case of type 4 Barrow classification, where you have ulnar and radial shaft fracture. There you go for both bone forearm plating fixation with 3.5 mm system, and appropriate method is used. The post-operatively, the supination and pronation movements of the patient should be achieved in a good manner so that our surgical fixation and reduction is absolutely fine. So this is the most common Monteggia fracture is the most common one of the most commonly seen fracture in the orthopedics OPD and any setup, and it has to be approximately fixed. And the mechanism you should understand for appropriate reduction, and the neurovascular examination is very important. The fixation of the fracture methods and other methods is also important. As we give importance to the distal radius fracture, we go for correction with BE slab. Here, appropriate reduction methods is done along with application of the above elbow slab. It is done in a emergency basis, and appropriate evaluation is done for the surgical fixation of the patient in a later day. So, thank you one and all for this opportunity. I hope you understood something about Monteggia fracture. Thank you.